And thank yourself that you're worthy of this education, taking time out to refresh and to be here with us all. I'm going to turn it over to Dr. Fong, and I just want to say a couple of words about him. He said I could cut out most of his bio. When Dr. Shaywitz is our medical director at Monterey Behavioral Health, and he couldn't be here with us. And I want to say it was for a good reason, but Dr. Fong stepped up and said, "What do you need, Renee?" And I honor, I mean, you flew in late last night, and he was helping us till midnight doing the slides. So I'm so grateful for all of the doctors and their participation and for being here with us. Dr. Fong is a clinical professor of psychiatry at the Jane and Terry Seminole Institute for Neuroscience and Human Behavior at UCLA. Dr. Fong completed his undergraduate in medical school at Northwestern University in Chicago. He then came to UCLA and finished his residency in adult general psychiatry in 2002 and was the first accredited addiction psychiatry fellow at UCLA Neuropsychiatric Institute. That just says a lot, because personally, when I was 30 years old and I was struggling from depression and addiction, I had to make a choice. Did I want to go to a mental health institution or an addiction treatment facility? And because of these caring doctors who have done so much research, we have come a long, long way. And I want to say thank you all for your dedication to this. Take it away.
Wow. Thank you, Renee. Thank you, everyone. We made it. How about that? Our first conference in 2+ years. You're on mute, though. I can't hear you. How many times did you see that? So welcome to UCLA. Welcome to our first inaugural Emerging Themes in Behavioral Health. This is our treatment-resistant panel. So I'm going to moderate this morning. I'm going to kick it off by doing some introductions and various things like that. But first, just look at this panel. This panel has over 120 years of experience in treating depression. I had 2, no, just kidding. But it's an absolutely wonderful panel. I have a lot of friends and mentors here. We're going to learn a lot about treatment-resistant depression. But first, where we are here today, we're at UCLA, the beautiful Luskin Conference Center. For those of you who have not been on our campus before, just about 300 yards to our south is our Resnick Neuropsychiatric Hospital, our flagship psychiatric hospital for children, adults, and older adults there. Also, right across the street is our Seminole Institute for Neuroscience and Human Behavior, where we do the work. I've been here since 1998. UCLA is home to me. Howard, I have to call you out. He's wearing a USC mask. So hopefully by the end of 2 days, we will transition that to a UCLA mask. So we get that. But thank you for that. And again, thank you, Renee, for putting this together. Genesis for all the logistics, and JD and all the good folks here. Dr. John Shaywitz is a dear, dear friend of mine. We went through residency together. That's why I'm here today. He is the medical director of Monterey. We wish him the very, very best, and he's doing a fantastic job for Monterey. With that, we're going to get started with our treatment-resistant depression panel. And first, you might say, well, what does that word mean, treatment-resistant? Learn more about that. But it's basically when we have an inadequate response to treatment that we know works for some, but not all. Medications, psychotherapy, and things like that. When I go back to when I was an intern in 1998, you know what was available on the shelf for medications for depression? There were very few. SSRIs were brand new. We had a couple of new things like SNRIs, Remeron were starting to come out. Now I think about fast forwarding 20 years later. If you said to me in 1998, you're going to be talking on a depression panel. It's going to be talking about ketamine, psilocybin, magnets, cannabis, looking at ways to talk about health inequities that I didn't even know existed in 1998. I would have been like, wow, I didn't realize the field would move that fast. That's really what we have here today, to talk about the theme, emerging themes in behavioral health. What's new? What's currently here that's being underused? What should be used more? And what should we do to bring more science and objectivity and things that work? Obviously in behavioral health, we see a lot of things. Did you know that there's over 1,500 licensed residential programs in the state of California to provide treatment for substance use disorder or mental health? 1,500. And Howard knows them all. Now, I always like to joke Howard because We've been friends for a long time, but that's an amazing number. It's an amazing number of different programs. There's diverse, wide range. And hopefully what we can shed light on here today is to bring some newer emerging treatments into those behavioral health programs, treatments that we know work. With that, let's get started with our very first speaker. I'm proud to introduce Dr. Sid Zissuk. Dr. Zissuk is a distinguished professor of psychiatry at UC San Diego. He drove all the way from UC San Diego. He's made a lifetime career of studying treatment-resistant depression, suicide prevention, grief, bereavement, and psychiatric education. He's been the psychiatry residency director at UCSD for a long, long time, and he's coming back to start that. But most importantly, I interviewed at UCSD back in 1997. You may not remember that. You do remember that.
You and Jonathan.
And all the others, and lost them all. And Sid's daughter is a dear friend of mine, Dr. Stephanie Zissuk, who's also in private practice here. So it's such an honor to be sharing the stage with a man who's dedicated his life to studying depression over the last 40 years. And I wonder if we had taken a picture in your office when I was a wee bit intern and applying, what that would have looked like. I had more hair there, but you look exactly the same as the 90s. So with that, I'm going to turn it over to Dr. Zissuk. Let me get this started for him, and he is going to give us an overview on treatment-resistant depression. So let me just flip over here. You can use this slide panel here. And so this is always the thing here. Usually I just hit this button. Yeah. All right. And as you would...
If you go into here.
This one? This one? There we go. Technical problem, something you don't see on Zoom anymore. Dr. Zissuk, please take yourself off mute.
Thank you. Thanks for the great introduction. And let me, so I'm going to be talking about treatment-resistant depression. Sort of. Tim stole everything I was going to say in all of my best jokes, so blame him for whatever I don't say. But one of the things Tim mentioned is what we had back in 1990. When I started, long before that, we had the tricyclics and the MAOIs. And what we have developed since in terms of the standard treatments for depression really haven't progressed us in terms of being able to treat more patients more effectively and get better response and remissions. There are all sorts of problems with the drugs and psychotherapy that we utilize for treatment of depression. Not everyone takes the meds as prescribed or follows our instructions during psychotherapy as prescribed, so that we don't get the full impact of what we're prescribing. Even if people do take as prescribed, many patients don't tolerate the meds we're taking or the psychotherapy that we are providing. And so tolerance is an issue. Even for those who tolerate and adhere and do everything we ask them to do and take the meds as directed and are involved in psychotherapy, the majority fail to achieve what we call remission, which is a relatively asymptomatic state. And even those who achieve remission, and we say, oh, they're successes, the majority of those have relapses and recurrences over time, very often within the first several months after they've initially achieved remission. So we have meds and psychotherapies that are effective, but not effective enough, not for enough people. And consequently, many folks, whatever we prescribe initially, require a next step or are defined as treatment resistant. And we don't have really good evidence-based standards for what should be the next treatment when someone fails the initial treatment. And in fact, studies that have tried to compare different alternatives have generally found they're all about the same. And so the guidelines that we utilize are really based much more on some expert providing an algorithm that is not particularly evidence-based, but is kind of their favorites, as opposed to really having evidence-based guidelines. So we need to do better. We need to find out more, and a lot of the newer treatments Tim was alluding to may end up being very helpful in that regard, but it may be too early to say right now. Okay. So given our lack of knowledge of what to do next, what do we do? And I think rather than jumping to what's the next treatment, do we add a med, do we switch to a different med, do we do a different psychotherapy, that if a patient isn't responding adequately to the treatments we're providing, take a step back and go through a more systematic approach before thinking of the next drug or the next psychotherapy. And that's the 8 Ds of treatment-resistant depression. First D is definition. What do we mean by not having a good enough response to the initial treatment? And it's more controversial than you might think. Those of us who do clinical trials look at remission as the gold standard for what is a good enough response. Remission means their Hamilton goes down to less than 6. They're relatively asymptomatic. If you ask patients, what do they mean by a good response, something Mark Zimmerman has done, you hear something very different. They don't talk about remission, they don't talk about symptoms. They want to feel better. They want to feel back to themselves. They want to be connected again. They want to see rainbows. They want to wake up in the morning feeling enthusiastic. None of that is in the DSM definition of depression. And so we need to align with our patients in terms of defining what is a good enough treatment and a good enough response. Often treatment-resistant depression is defined in a lot of trials now as having had at least 2 different trials, 2 different treatments, usually medications. Psychotherapy is out of the loop in this, usually. 2 different medications that haven't achieved remission. But that doesn't account for, well, what about if they just couldn't tolerate any medications? What about other kinds of treatments? Some people would say 3 or more. Some people would say don't say it's resistant until after you've also failed ECT or a monoamine oxidase inhibitor. So there's no unified definition. And more recently, there's been an alternative conceptualization of treatment-resistant depression, and that is get rid of that term and instead call it difficult-to-treat depression, as defined by people who are still struggling with aspects of depression despite the traditional efforts at treatment. And that would include a broader umbrella of what we call treatment-resistant depression. That would include people who haven't been able to access psychotherapy, who haven't been able to tolerate medications, who may have been able to tolerate medications and may have even gotten better, but then get depressed again despite our attempts at maintenance treatments to prevent other episodes. So it's a much broader scope. And also the notion of treatment-resistant depression, that's a difficult one to bear, that I've got this depression that's resistant to treatment. That, that makes you feel fairly hopeless. Difficult to treat depression, we've got a challenge we can work on together. And it really connotes a more collaborative approach, collaborating with not only the patient, but with family, with other doctors, to try and help them maximally manage this lifelong illness and maximally optimize functioning, quality of life, as well as symptomatic relief. So I favor difficult-to-treat depression over treatment-resistant depression now. So that's definition. Diagnosis. If somebody isn't responding the way we'd like to see, it may be time to reassess diagnostic issues. Did I miss a bipolar disorder, which not only may not respond to a traditional antidepressant, but may have untoward side effects, like increased anxiety, hypomania, mania, etc. Did I miss a depression with psychotic features that is easy to miss when you're treating somebody who's depressed and feeling very worthless and low energy and maybe not giving you a totally accurate history when you first meet with them? If they have psychotic features, they're not going to respond as well to an antidepressant. They may even get worse. You may need to have an antipsychotic treatment. Did I miss somebody when Jay Amsterdam at Pennsylvania started a treatment-resistant depression program? They did workups on everyone coming into the program, and they found a whole lot of them actually had sleep apnea that had never been diagnosed. And when the sleep apnea was treated, Depression was no longer treatment resistant, but responded very well to the normal treatments. Did they miss a metabolic disorder? I remember myself as one of the residents that would have been in your class had you come to UCSD, my nemesis, and I evaluated somebody, another resident from another program, thought they had a major depression and referred them to one of my top residents to treat. And that resident, doing as I say rather than as I did, before starting treatment, did a very thorough workup of that person and discovered significant hypothyroidism. And when treating the thyroid, the depression disappeared. And in the 30 or so years since, he's never let me forget it. But are we missing metabolic problems? Are we missing other medications? Are we missing people who are continuing to drink while we're treating them? So diagnostic issues are very important. Also, in terms of diagnostic issues, if somebody's going through a horrific life event and challenge, their depression may simply not respond until that's dealt with. And certainly having psychotherapy as part of the treatment and psychosocial interventions as part of the treatment are critical. The next D that we go down to is dose. Have they had enough medication? Are they taking a high enough dose that really optimizes their likelihood of getting better? And I see so many people, and I'm sure you all do as well, that are referred to us saying that treatment-resistant depression who have been on their 20 milligrams of Prozac for the last 5 years, and no one thought of, gee, what about 40 milligrams? What about 60 milligrams? So optimizing the dose is critical, and so many people are underdosed when we see them. The next D is duration. How long do you treat before you say this depression isn't responding? And we really don't have good guidelines. If we were all polled as to how long to treat, I think we'd all come up with different answers. Most people say, we learned in STAR D, Andy and I were both investigators in STAR D, we learned that at least 50% of people who ultimately have a remission, symptoms go away, by 12 weeks, at least 50% of them don't go into remission until after 6 weeks. So you need to be patient, and we learn to be patient. But we've also gotten some more recent data that suggests, well, if you don't have at least some response within 2 weeks, the likelihood of your achieving remission, no matter how much longer you treat, is about 10%. So that although we've learned to be patient, we also know that if someone's not responding at all within a couple of weeks, even if you optimize the dose over time, that's a bad prognostic feature in terms of whether they're going to ultimately respond. So what do you do at 2 weeks? Do you change meds? Well, no, that's a little bit early, but you really do perk your ears up and want to monitor and maybe see that person again within at least a week or two while you're optimizing the dose. And if you don't see any symptom relief within 3 or 4 weeks, it may be time to consider switching to a different approach or augmenting with something else. So dose, duration are important. Doctor, another one of the Ds that I've more recently added. There's a very, very good study done years ago, actually, looking at imipramine plus psychotherapy, either both. Anyway, the results of the study was they're both about equally effective, psychotherapy and medication. The more severe the depression, the more likely it is that medication should be in the mix. But what they also found is that about a third of the doctors in that study had really, really good treatment responses no matter what they did. So even if their patients were on placebo, they had pretty good responses. About a third of the doctors in that study treating patients, no matter what they did not have good responses. That even when they were treating with the active medication, their patients weren't getting better. That suggests that maybe even more important than which medication or which psychotherapy is what doctor is treating them or what clinician is treating them. And maybe instead of switching meds, we ought to be thinking about switching doctors. They also found that those doctors that were in the top third, that had really good responses, even if they were prescribing placebo, were ones that were compassionate, empathic, took time to develop a therapeutic relationship, were warm, collaborative in their approach to the patient, had a plan, etc. So the doctor is the fifth and maybe the most important D of all. Now we're down to 6, which is different approaches. And that is, gee, are there other things that we ought to be doing? Is the person exercising? Exercise is healthy. Now, a lot of times when you're depressed, you don't have the energy or motivation and you can't. But as someone's starting to get better, having regular exercise, sunlight, et cetera, are helpful. But are there other things to do? We talked TMS, ECT for very severe depressions. So considering what are some of the different approaches that we may be including, and as a psychiatrist, I'm ashamed to admit it, but in my list of what are the different approaches, I include psychotherapy because the vast majority of psychiatrists don't include psychotherapy in their toolbox. And so if somebody isn't responding adequately to treatment and they haven't been in psychotherapy, well, shame on that doctor for not getting the patient into psychotherapy or doing it themselves. Okay. It's not until we get down to 7 before we hit drugs. And that is, if you've gone through all the others and the person's still not responding and they're seeing the right doctor, they've had the meds long enough, they're on the right dose, then we begin to think about, do I switch, do I augment, and we'll hear a lot more about those approaches, so I don't need to get into them. And the last D is determination. And that is a lot of patients, no matter what we do, and we found out again in STAR-D, that even after a year of 4 or 5 different approaches, seeing the person regularly and often, even with all of that, at a year, about a third of patients are still struggling with their depression and having relapses and recurrences. And so we need to recognize that this is a lifelong illness, and optimizing health, well-being, function may be our goal, and we may shift into more of a chronic disease model as we do with chronic pain, recognizing that this is going to be a lifelong struggle, and we need to help the person see that and help them live with this disorder that is going to be recurrent and interfering with their life from time to time, and minimize that interference. So just in one more minute, I've got we recently completed a study at the VA, treatment-resistant depression study, where people who are treatment-resistant got a variety of different treatments. We found that several factors were associated with lack of remission in that study. If you were unemployed, you didn't do as well. So get the person a job, help them have shelter. More severe chronic, the higher anxiety people needed higher doses, needed to take longer. Comorbid PTSD didn't do as well. The one I want to pay particular attention, one of my passions in psychiatry is grief and bereavement. We found in this group of veterans that about a significant number of them had lost loved ones in their lives. Of course, everyone in this room has lost loved ones in their lives. It's common. We found that about a third of them, even though the most significant loss was about 9 years previously, about a third of them still felt they were struggling with their loss. Many of those felt that their depression was related to their loss. Many of them still yearned and pined for the person who died. This was unrecognized. In the charts and the referrals we got, it was never mentioned. But because I was doing the study, we had a bereavement screening questionnaire at baseline. Well, we found that group that was still struggling with their loss, who would meet criteria for what is now called prolonged grief disorder, had more severe depressions, more recurrences, more suicidality associated with their depression, and didn't do nearly as well with our treatments, suggesting that a large number of people who are so-called treatment resistant may either have instead prolonged grief disorder or along with the depression prolonged grief disorder. And if that's not attended to, their depression isn't going to get much better. We also found people with a history of childhood adversity didn't do as well with whatever medication was prescribed. And again, psychotherapy needs to be added into the mix, if we're going to be providing the best treatments possible. So with that, I'm going to end and turn it over to people who elucidate some of those other points in the last couple Ds. Thanks.
Thank you, Dr. Zisuk. And everyone's got a ton of questions, so what we're going to do, we're going to go through everyone's show and then write down your questions because you have them, and that we're going to leave about 10 minutes at the end of our panel and make sure we get that, and we'll use the break a little bit to also get some of these questions answered. Next up, we have for you Dr. Merrill Sparago. All these years. It's okay. Dr. Sparago and I have known each other since residency back in the 2000s. He graduated 2003, I think, 2004, coming to us from University of Maryland. He did a work in perinatal psychiatry, worked at our UCLA Women's Life Center, and over the last several years has now crafted himself in a private practice on Olympic and Sawtelle, right by those wonderful restaurants, right there on Sawtelle, where he specializes in treatment of perinatal psychiatry, mood disorder, and in the office, he does TMS and ketamine. So with that, Dr. Sparago is going to come up and talk about treatment-resistant depression in the private practice setting. In other words, things that doctors can actually do when the doors close. Take it away, Merrill.
Thank you, Dr. Fong, Dr. Fong. Anyway, this is my buddy, and before I start, first of all, I want to thank everybody for being here. I mean, this is an incredibly important topic, and I would say that I would not be here if it wasn't for the people on this panel. Dr. Luchter, who is my mentor through my research fellowship, and also an attending physician who I relied on to learn so many different things. Dr. Zisuk, who I still call and consult when I don't know what to do, and he's always responsive. Down in San Diego. It's not because I know his daughter. His daughter doesn't like me, so don't think that that's the case. And then Tim, who was a co-resident, who was a couple years ahead of me, who taught me when we were on call. And I still go to him when there's issues with substance abuse and addiction. And so the first thing saying all of this is a collaborative approach. Nobody's an individual, whether they're a patient, whether they're a treater, or whether they're something combined. And so, you know, with what Dr. Zisuk said, one of the key words in treatment is augmentation, right? Which is, what do we do to add something in that makes things better? And so, you know, what's interesting is this is the way I used to do my homework. This is why I pissed off my teachers. This is why I pissed off my mom. And there's actually water that I spilled on here and coffee, on just like everything else that I've done. But the title in this is actually Doctoring in Depression. And that's what I want to follow up on, because at the end of the day, I want to just add two things. A couple things. Treatment-resistant depression. Let's just know what that is. That is a research diagnosis. That came out of research. It did not come out of clinical practice. And so at the end of the day, psychiatry has this incredibly smart way of making people feel worse about what they have. Have anyone heard of blood pressure deficit disorder? No, we don't have a deficit. Glucose deficit disorder. No, but attention deficit. People already feel defective. It's not a deficit. It's a requirement for stimulation. We don't say that people have treatment-resistant thyroid disease, but we say that they have treatment-resistant depression. Why? That doesn't make anybody feel better up to their point. And really what I say to people is continuation of your treatment for depression. And most importantly, what we're talking about here is standard treatments. So with that research diagnosis in place, research diagnoses don't translate into clinical practice, even though I had no idea that Dr. Luchter did STAR-D, and now he's like more of my hero. But anyway, the understanding of how they did their protocol, everybody got Celexa. That was it. And then they went on and on and on and on. Psychotherapy wasn't included. And most importantly, I think what I want to follow up with Dr. Zisuk said is when I started training, you give someone an antidepressant, you say come back in 4 to 6 weeks. That's it. And if the clinical practice is I see you for 10 minutes and see how you're doing, that's not what I call doctoring. In my office, everyone's seen for at least a half an hour, and most of my patients, if they want to, are in psychotherapy with me or somebody else. But if they're not in psychotherapy, it's not because they're necessarily resistant to it. Some people can't do it. But we always need to learn about ourselves. I go every week, much to the dismay of my therapist, who's probably just totally over me by now. But anyway, I got a lot of mother issues, so, that's just me. My point being is that doctoring includes treatment. So do not use research to dictate what happens in your life or in clinical practice. We need research. We need algorithms. We need exactly what Dr. Sisek talked about. I almost went into oncology. Everything in oncology is evidence-based. We do protocols. But the thing about oncology is you are dealing with a disease that doesn't care about what you think or feel. It's all about interaction with the body, whereas this is the mind. So I already went through treatment-resistant depression, but before we go into even what depression is, I want to just give an idea of how I think about it and how I explain it to people. How do I do this, Tim? I just press this button? Do I do that? I use the arrow. Wait, I use a Mac. PCs are just, what do I do? All right, so basically what do I want to do? I want to find a base framework for understanding the definition of treatment-resistant depression, and we've kind of done that in some way. Insurance companies use Ptsd to preclude treatment. They want people to fail for antidepressants as well as augmenting strategies and evidence-based psychotherapy, which is the very last step in Ptsd. That's how that's used in some way. But at least when I first started doing TMS, what Dr. Luchter talked about, in 2009, I started using TMS so that I would be able to treat women with an alternative who did not want to use medications during pregnancy and the postpartum. At that point, it was impossible to even get it covered at all. Now there's a huge barrier to entry, but at least it's covered because people learn based on their research that if you keep going with antidepressants, you're going to end up getting somebody hospitalized or dead, and it's much more costly to not treat with another modality rather than to continue to treat. So broadening the conceptualization of understanding, communicating with patients, that's the doctoring part. And then we're going to look at the idea of how I approach in my practice, the idea of ketamine versus TMS versus medications. And I probably won't get to this, but I want to let you know that I do perinatal mood disorders. I did a talk for Maternal Mental Health Now about 3 weeks ago on treatment-resistant depression and perinatal mood disorders. I think it's still on their website, but everything includes every population, including women, including pregnant women, and that is something that I just want to mention. Now, okay, here's the way I think about depression, okay, in some way. We have our brains. Our brains are an electrical chemical organ. The only difference between the brain and the heart is the brain can actually create a functioning mind. Like the heart, the brain needs to function in rhythm. We believe for some reason that no matter what happens, we can use our mind to influence what's happening in our brain. Try using your mind when you're in a REM sleep rhythm. Try using your mind when you have a rhythm that's related to dementia. And so, for example, if I were to evaluate somebody and to augment Dr. Zisik's point, everyone that comes to my practice gets a clinical evaluation based on my training at UCLA. They don't fill out checklists, even though those are important. I don't use a checklist to determine what's happened. I sometimes know what their treatment has been to give me a little bit of a head start, but at least it's an hour and a half of getting to know that person, because if I don't know really what's happening in their life, I can't determine what the best treatment is. That said, if I were to have somebody who was depressed and I sent them to my neurology buddies for an MRI, they could do an MRI and we can label every part of the brain, them better than me most likely. And I would say, well, that's all well and good, where's the mind? What are they going to say? I don't know. I mean, there's been maps of the mind by a doctor, but nobody knows where it is. It's a construct, like The Matrix, which is a good movie. That said, my point being is our brains need to be in rhythm to be able to use our minds, and the most painful thing about depression is the inability to use your mind, and people feel like they have failed when they cannot use their mind to overcome what's happening in their brain. Then there's the idea, well, why can't you be grateful postpartum? Well, you have everything you've ever wanted. Why not be grateful? That will help treat you. That's a bunch of, can I use the word, can I say BS? I just said it, it's BS. Think about it this way. Would you ever say to somebody, If you were just grateful for the beautiful fresh air, your pneumonia wouldn't be there. That's insane. It's not there. It's the fact that you can't experience the joy based on the illness is what happens. So I want to look at this. This is a normal heart rhythm. Everyone's seen an EKG, right? Someone's functioning fine. That's an arrhythmia. That's in the ICU. How well is this person going to be functioning? Normal versus not, okay? This is a actually reasonable PET scan, but this looks at what the brain is like. When people are depressed, it's lights out. That's their brain. This isn't their mind. And if it's lights out here, all of this stuff is on. Cats away, mice play, all the primitive stuff. The job of the brain is to think. A depressed brain is just a brain full of thoughts. And so if we look at depression as an arrhythmia of the brain which impairs function, any treatment for depression should clear the arrhythmia. Even that arrhythmia is unresolved grief, which I'll get to in a moment. Let's look at a computer. I use a Mac. A Mac functions on all cylinders. It is doing a ton of things. If a Mac gets overwhelmed, what do you get? It's the spiral of doom. That is the brain in depression. We just spin and spin and spin and spin, and we can't get out of it. We can't force quit our lives. We can, that's suicide. But that's not a reasonable alternative. We can hope that we, can reset it. But a Mac will not call another Mac up and go, man, I'm really a loser. I couldn't connect to the internet today. You guys were surfing and I suck, right? I mean, that's the thing. But if we clear the arrhythmia, then all of a sudden we're humming again. So I'm going to hold this slide for 1 second to look at the idea of doctoring, right? In my practice, based on what we've learned from research, is people are checked in on a week, and then they're seen in 2 weeks, and they're seen for a half an hour. And the reason why is because if there is no response, well, what does that mean? Are they tolerating the dose? Can they even do it? In private practice, I don't necessarily use clinically available doses. I can compound medications. Some people just can't tolerate them. I'm treatment resistant because every time someone gives me a prescription, I have side effects. I've treated people with 0.5 milligrams of Lexapro and got them in remission. So dose isn't necessarily too little, it can be too much, right? And so, with that said, is as I'm looking at people, when people come in to my practice, there is not one size fits all. I find out what the size is and see what it fits. If a woman is having a postpartum depression and she is taking care of her child all day long, I'm not going to recommend TMS where they have to come in every day. I've just given them an option so that they can't do. There's other ways to work around it, but we have to have an individualized treatment plan for every patient. That's the idea of medicine. We get a plan that works for somebody, including psychotherapy, and if it doesn't, we figure out why and if there's anything else that we can do. So, with that said, is Dr. Luchter is going to talk about TMS. I'm going to say this briefly. TMS has been the most effective treatments for depression I've ever seen in my life. I didn't think it would work. I thought it was BS. Right? I said it again. I'm going to get in trouble. I got to call my mom. But it works, and that's where I came up with the concept of a rhythm. The rhythm of the brain is set here, right? And Dr. Luchter will talk more about that. Ketamine has been out for treatment. Anesthesiologists have been using ketamine forever, and ketamine was discovered as an anesthetic in prisons. And in the person who discovered it, and some doctor noted that, wait a minute, these people are less depressed when they wake up from their treatment. Well, of course, all exciting findings that are new are blown off completely, and it took many years for it to come back. Anesthesiologists recommended it, but anesthesiologists aren't psychiatrists, right? And so when they treat people with ketamine for depression, it can be incredibly effective, right? And it is not to say that they can't do it, but they have a way of doing things that's different than psychiatry. So for example, I had a patient that came in for a ketamine consult. I said, well, what happened? They said, well, I went to a clinic, I filled out a piece of paper, 5 minutes later I was strapped up to an IV, and I had the worst experience of my life, and I thought I was going to die, and they left me in a room alone. When I treat people with ketamine, I sit with them for the first treatment, no matter what. Sometimes more. I've done psychotherapy all through a ketamine treatment, and I'm going to get to that in a minute, because at the end of the day, part of the use of ketamine is it does open things up that are blocked, right? And so with that said, when someone comes to me, another example, I just got called yesterday. I have a patient that's not getting better. They want to be treated with ketamine. And I said, well, that's great. They can come in for a consult. No, they want ketamine. And I said, well, then I can't treat them, because I don't give people necessarily what they want. I mean, I get what I want, thanks to my wife. But the point being is it's a dialogue, and they might want it based on what they believe about it, and it might be indicated, and that's absolutely fine, because people have autonomy. They can make decisions, but they have to be evaluated. So let's look at this. Ketamine is one of the more complicated medications, and we've always talked about serotonin. This NMDA receptor that it works on is absolutely wacky. I don't understand it. And one of my colleagues, because when I was doing research about this before I started doing it, back at University of Maryland, came up with a 30-page paper about the mechanism of action of ketamine. If there's 30 pages to explain something, that's 29 pages I don't want to read. The brain. When Dr. Zissik is talking about grief, unresolved things, there is a blockage there. And when you look at the interchange of a freeway, let's just look at the 405, the 605, the 10, whatever it is. If that is what is happening in someone's brain, because they can't get past something, what's going to be the upstream traffic? Nothing moves. Example, I have a woman that I treated recently. She's been depressed forever. Her family member committed suicide. Her belief was it was her fault because she's a physician and she could have done better. It doesn't matter what reality is. It only mattered what she believed. And through the course of ketamine treatment, one day while I was sitting there with her, she realized, wait a minute, it's not my fault. And then her brain looked like this. That improvement wasn't some magic based on the interaction of ketamine with the NMDA receptor. It was about she could never be free. And if you're a doctor and you killed someone like your family member, you're not going to walk around being happy unless you're completely insane, right? So, well, let me rephrase that. Maybe the family member deserves it. Wait, take that off the record. My point being is that we have to look at different treatments differently. So if I'm evaluating someone and I realize there's a big trauma that's blocking them, I might recommend ketamine over TMS. If there's something that is just not there in any way, shape, or form, there's no bipolar disorder, no concomitant personality disorder, there's just this lackluster, blunted arrhythmia in the brain where they're flat, that's where I'll recommend TMS. And in some instances, I do both. Because if somebody is so sick, why not do everything that you can? There's no other field in medicine where you go, well, you have to fail this before I can do that. You have to fail this before you can do that. They have failed enough by the time they've reached in my office. And what I mean by fail, they feel like they failed. They just haven't responded. When they respond and we do everything we can in doctor, people feel taken care of. And the best medicine ever is being cared for by another. And I'll stop with that.
Thank you. And again, for clarification, when you do ketamine in your office, you're not using IV. You're doing it.
I actually do both.
Okay.
I do.
You can use the mic right there.
I treat people with both.
Okay. Thank you. All right. Moving on from ketamine, and I'm curious, how many out there have access to a physician that uses ketamine for depression? So again, that's not 100%, so that's definitely some of the work we can do. How many folks out there have access to a team that can do TMS? Amazing, isn't it? And that's what we're going to talk about next. Next up is Dr. Andrew Luchter, who is a distinguished professor of psychiatry here at the Semel Institute for Neuroscience and Behavior. And he wears a lot of hats, and some of the other hats include executive vice chair of our Department of Psychiatry. That means he is one of my bosses. Can I get a raise? No. No, well, just my wife. Third, he's also the associate director of our Semel Institute Again, people get confused. Our Semel Institute is where we do the research. Resnick Neuropsychiatric Hospital is where we do the psychiatric care in the hospital and the outpatient settings. And he's also the director of the neuromodulation division of our department, which includes the TMS clinical and research service. 10 years ago, there was no such thing in our department. Correct, Dr. Luchter? So he built this TMS service from the ground up, one magnet at a time. How about that? So with that, Dr. Luchter is going to give us a tour of what's happening inside the brain, outside the brain, and his take on actually the effectiveness of TMS for treatment-resistant depression. Dr. Luchter, take it away.
Thank you very much, Tim, for your kind introduction. And let's see here. There, that worked. Okay, good. So thank you all for coming out today. You've heard a lot about different treatments, different ways to conceptualize depression. Rather than focusing on any one treatment, what I'd like to do in just a few minutes here is to talk a bit about a framework for thinking about what causes depression and ways that we can approach it and integrate different treatments that we have. This slide I like to call all of psychiatry in one graphic. It's really a framework for thinking about depression. So we start down here in the lower left corner at the level of the genome, the level of DNA. So, you know, the building blocks of what makes us what we are. And then we go up by level, going to RNA, so the products of gene transcription going on to proteins. Then these are formed into cell pathways within the brain. You go up a little bit higher, you get to cell connections, the synapse. You go to circuits in the brain. Then you go to larger constructs like brain networks, different regions of the brain that are connected to one another, going up finally to the whole brain itself, and then finally to the level of the person and, you know, the phenotype of a person with major depression. Now, this obviously is just a cartoon schematic here. There are many, many more levels than that. But it does give you the overall picture that, you know, we can think about this illness at different levels. So for example, starting in the lower left corner, you know, is depression a genetic illness? Well, yeah, in part it is. You know, we know that everybody who's depressed has probably a genetic predisposition to getting depressed. Is depression a neurotransmitter disorder, something around the level of the synapse? Well, yeah, we know it's that too. That is, there are differences in chemical neurotransmission that come out when somebody is depressed, and that we can use medications and other treatments to try to ameliorate. And then, you know, is depression a disorder of the brain or the person? And we know it's that too. That is, we can intervene at a high level with psychotherapy and psychosocial treatments. You'll be hearing more about those from Dr. Wyatt in a few minutes. Those work as well. So, you know, it's a very complicated schematic. So to try to simplify things a little bit, you can try to group things together at different levels of biological complexity here. So just putting together things in the lower part of the slide, these are things that are going on at the level of the single cell. The genome, turning genes on and off, making proteins, things like that. Taking it up a level, you can go to cell-to-cell communications. So the synapses where nerve cells are talking to one another, cells are firing, chemicals are being transmitted back and forth between cells. And then lastly, you can go to sort of the highest level of all here, and that is cell networks. That is networks within the brain, passing of information back and forth between different brain regions. Now, we talk about these, or I've talked about these so far as discrete levels, but in fact, they really aren't. That is, everything gets integrated. I mean, that's what the brain is. It's the great integrator. It takes information from the lowest level and puts it all together to form very complex moods, thoughts, plans of action. So we know that there are these bottom-up influences. That is, what's happening at the very lowest level here, at the level of the genome, is affecting not just the structure of the brain, but also human behavior. When you have certain genetic makeup, certain forms of neurotransmission, you end up with depression. We also know that there are top-down influences here. So what happens in the environment, what happens to the individual person in terms of lived experience, also affects how their individual nerve cells are functioning, and probably also helps turn their genes on and off, and what proteins are expressed. Now, it doesn't seem obvious until you really think about it. You think, well, it kind of has to be this way. That is, if there weren't these top-down influences, something like psychotherapy, how would that possibly work? What happens in the environment, what the person's lived experience when you talk with somebody, that has to affect what's going on at lower levels of biological organization within the brain here. So this is kind of a general framework for thinking about mental disorders and about depression in particular. It also can be a framework for thinking about treatment and how we use treatments and how we go about integrating treatments here. So, the classical treatment, well, actually, I guess the classical treatment for depression is psychotherapy. That's where the whole field got started. So that really was intervention at the very top level. And that was really the first revolution in psychiatric treatment, which was more than 100 years ago now. Then, about 50 or 60 years ago, we had the neurochemical revolution, and that's where we started intervening at the level of cell-to-cell communication. Ideally, the kinds of treatments we would have for depression, kind of, the holy grail, is what's going on within the single cell, being able to turn gene expression on and off, change how cells work. We don't yet have any of those treatments available, but we do have a whole host of treatments that are neurochemical that come in at the level of cell-to-cell communication. Antidepressants, anxiolytic medications, the atypical antipsychotics, ketamine, all of these drugs are changing cell-to-cell communication. And you heard from Sid and from Merrill about the STAR-D study and sort of the limits of neurochemical treatments. That is, we're very good at getting about a third of the patients well with the first thing that we try. And then we try successively another medication treatment and yet another and yet another. And every time that we try one more treatment, the likelihood of success is going down, down, down. Eventually, if you try enough, you'll get 60 to 75% of patients doing a lot better, but it's sort of a law of diminishing returns if you just sort of keep doing the same thing over and over again. And this is where some of the newer treatments, some of the sort of higher level treatment interventions here, interventions at a higher level of biological organization can help. And these are kind of the neuromodulation treatments. So I'm not going to talk about TMS or other neuromodulation treatments in any great depth today. Happy to take questions on that later if y'all want. But what we're doing is we're intervening in a fundamentally different way. We're coming in at the level of brain networks. So we're picking a particular target of the brain, we're introducing some low-level energy into the brain and trying to kind of rewire it. We're changing how the brain is sending information back and forth. We're inducing what's called neuroplasticity, helping the brain kind of remodel itself. And by changing information flow and rewiring things, we're hoping to get a lot more patients well. And this is where, I would remind you of what I talked about a moment ago in terms of top-down and bottom-up influences. Medications, we're coming in here at a little bit lower level of biological organization. With the neuromodulation treatments, we're coming in at a higher level, but there's crosstalk between these different levels. And in fact, everybody who we treat with TMS, and we're treating about 40 patients a day at our 2 TMS clinics, they're virtually all on medications. And the success rates are very good, in part because they're virtually all on medications. Most of them are in psychotherapy. If they're not in psychotherapy, we actively encourage them to get into psychotherapy, because the most effective treatment is really integrated treatment. So all of these treatments are effective. The most effective treatment is, in fact, combined treatment. Now, the one major difference I will point out between medication treatment and TMS and some of the neuromodulation treatments really has to do with the success in the so-called treatment-resistant patient. So as I mentioned earlier on, the first medication you try, you stand about a 30 to 40% chance of getting somebody into remission, closer to 30%. Then you try a second medication, and maybe you pick up another 20%. And you go to the third and the fourth, and you get 10% or you get 6%. So it's sort of the law of diminishing returns. The nice thing about TMS, and to some extent ketamine as well, is that that law of diminishing returns doesn't really apply that well. That is, you stand a much better likelihood of getting somebody well by switching from medication to TMS than you do just keeping trying medication. And it's been shown now in several studies that the response to TMS is not really governed by previous treatment resistance. That is, you take a look at somebody who's failed to benefit from 1 or 2 antidepressant medications versus somebody who's failed to benefit from 5 or 6, and the likelihood of responding to TMS is about the same. We're always getting somewhere between 40% and 60% of patients significantly better. So I think that is sort of how these treatments can work together. I mean, we're really talking about interdigitating treatments here, combining things to get patients doing all the way well. And I do want to emphasize really that we also want to be intervening at the highest level here of organization. That is the level of the person. We want to be looking at psychotherapies. We want to be using psychotherapies to try to get patients well. One of the challenges we face in TMS is we're treating patients who have, I evaluate patients every week, and I'll say, when is the last time you felt well? And not uncommonly, the answer is 5 years, 6 years, a couple of decades, or never. And we're now starting to have success with some of the neuromodulation treatments in getting these patients doing a lot better. And the hardest thing for many of them is recovery. That is, they say, I'm not used to feeling well. I'm not sure this feeling is going to last. It can be quite jarring. So we want patients to get into therapy. I'm always referring patients for CBT and other therapies to try to keep them well. And of course, we also have to look at the social context, the milieu. We have to be looking at community interventions. We have to be looking at psychosocial issues in the environment. And I'm looking forward to hearing Dr. Wyatt's comments on sort of the broader context in which we treat depression. So I'll close my remarks here. I just want to say again, first of all, thank you all very much for coming. And secondly, this is a complicated kind of situation to address. It really takes a team approach of psychiatrists working with therapists, working with case managers, working with as part of a whole team to get our patients doing well. And with that, I'll thank you very much for your attention.
Thank you so much, Dr. Luchter. And again, please ask him some more questions. And again, I can't emphasize how rapidly the field has shifted, right? Imagine 10 years ago, we had all heard about this, we heard rumors about this, whispers about that, and now you're treating 40 patients a day at UCLA. That's really, really remarkable. And we have more and more outpatient practices and programs that are using TMS, so that's definitely something to think about integrating. Next up, it's an absolute pleasure of mine. This is Dr. Gail Wyatt. Dr. Gail Wyatt is the endowed chair, the Dina Bat Yaakov Endowed Chair, Distinguished Professor of Psychiatry here at our Semel Institute. She also has a lot of amazing hats, including the director of our sexual health program and the director of our Center for Culture and Trauma and Mental Health here at UCLA. And she's the first African-American woman to be licensed as a psychologist in the state of California. How about that? How about that? She's a dear mentor of mine, a friend of mine. She's on the same office floor as I am, and it's probably the worst part of the pandemic is I haven't been able to see her and her team just kind of wandering around, like trying to steal coffee from each other. That's what we used to do. So with that, she's going to talk today about a new take on why things don't work out, and giving all of us who do therapy, who do education, who do research, who work with mental health to figure out, well, maybe we ought to be thinking differently because we might be missing something in front of us all these years. So without that further ado, Dr. Wyatt.
Good morning. It's a pleasure to be here. Thank you, Tim, for that personal introduction, and it's a pleasure to be on a panel with all white men, except for Tim. Gets to sort of what I'm going to talk about, but I'm not going to throw all of them under the bus, because it's what I want to present to you has a different take on it. My question is, how can you treat depression when you haven't asked the right questions? So I want to back us up a bit and move us back to asking about experiences that occur every single day that we don't ask about, and that has to do with racial discrimination. So I have been doing research at UCLA for 49 years, my entire life, and it's been a pleasure to be there. I've had many, many honors and many opportunities to do research in mental health, and mental health disparities in particular, because I feel that when you're talking about who's getting treated, you're only talking about certain people, aren't you? For the most part, people of color do not have the opportunity to get any kind of psychiatric treatment, don't even get a chance to come to the Simmel down the street, don't get an opportunity to have long-term therapy. Usually if therapy is offered, it's very short-term. And so we are only addressing the needs of certain people today. I'm hoping that we can begin to expand your thinking, since many of you are in practice. My center, as Tim mentioned to you, looks at mental health disparities. So the work that we do tries to identify where it is. And I must tell you that I'm not a traditional licensed clinical psychologist. I don't believe in the DSM-4 or 5 for the most part, because I don't believe that they are assessing the experiences of people of color. So that means only certain people get their insurance policies to pay for their treatment, and those people who don't say yes to the right questions don't get any kind of care. So if we're going to marginalize it that extremely, we've got to talk about what's left out, and then as a consequence, who is left out. Okay, so I'm putting up on the screen first a question that we ask in the research that we're doing now on cardiovascular risks and symptoms of trauma in HIV-positive men and women, African American and Latino, in English and Spanish. And this intervention has been developed by my team through the Institute of Heart, Lung, and Blood at NIH. We have been continuously funded by this and other studies since 1980, and I don't think any of these young men were born when I started. So, so I've been at this a long time, but this particular intervention does give us the opportunity to ask about racial discrimination. And this is the question, because I knew if I didn't show you, you'd want, well, how do you ask those kinds of things? If you don't ask, then you don't know whether their symptoms of depression are as a result of microaggressions that occur every day. I can give you a very classic one that I experienced, and that is being mistaken by my research assistants. So when we're all together, and people come on the ward, they look at me and they look at all the other people who are hired by me, and they address Dr. Wyatt to everybody but me. Now, some people might say that's explicit bias, the fact that you can't even entertain the fact that the person who leads the team, might be a woman of color. Or it could be implicit bias, where you're not even aware that you're doing it, but somehow it just doesn't seem plausible that the person who's, on that wing and with that group could be a woman of color. And then I'm not tall, so you can go by other characteristics and say, well, the shortest one couldn't possibly be her. So I just stand there and wait until they finally get around to me, because my team has been told, don't give it to them. Require people to ask, because then they will identify something's terribly wrong if I have to ask, why wouldn't the woman of color be the one who's leading the team? And what is it in our system that perpetuates the thinking that I would probably be the last person to have that kind of honor? And what did I go through to get it? Okay, so the question that I want to show you that we use is, because of your race, ethnicity, how often have others thought you couldn't do things or handle the job? That's just one question. And so we ask, and this is in the last month. Never, rarely, sometimes, often, and very often. Okay, that's one way of asking. Now, some of you are aware of David Williams at Harvard. He's a dear friend. He asks about daily hassles. His assessment is more intense than ours. He asks today, in every day, what happens to you, okay? In your day-to-day life, how often do any of the following things happen to you? And then he gives, those are the questions that he asks. Both of us use brief assessment skills, and I know that some of you may have an issue with using measures, but we simply don't know anything about discrimination, gender, sexual orientation, ethnicity, race. We don't know anything about it. So if people experience microaggressions, which are those daily little jibes that I just described to you, you would know it. They don't give it to you, and you wouldn't know it. So you may be treating something that you don't know anything about, and there is no one treatment for a person who experiences microaggressions. So what are you going to do? I can only share with you what other people do. But I think it's important that we look at the need to assess what goes on in people's lives that we're not asking about. Racial, ethnic discrimination is only one. We developed the UCLA LADS Life Adversity Screener based on my work over decades having to do with trauma, all kinds of different traumas. We were the first research team that identified racial ethnic discrimination as a form of trauma. This is something that happens in almost everybody's life who's a person of color, but it's not even in the organizations that we use, and we don't have panels on it, we don't talk about it. So I have to really thank Renee for adding me to this panel, because I think, you got to get out of the box, essentially, in order to see what you're missing, all right? So we have a brief screener based on the questions that we ask, and I get most of my money from AIDS research, and you know why? Because I get to ask about sexual experiences. You can't assess sexual traumas if you can't ask those questions either, and it's not funded in every division of NIH. So HIV gives me the opportunity to look at transmission, what people learn, what they need to learn about protecting themselves, but also to ask about their sexual lives. I have an article that's getting ready to come out in the American Psychologist about part of my career, and one of the issues talks about how, as the first person of color to receive a K award, I had to develop questions to ask about sex. We didn't have any that were taught in professional schools. So we're developing the methodology as we go along, and we ask about these 5 experiences that I'm going to show you, and we found that, let me ask you, which one do you think best predicted symptoms of depression and PTSD? Which one? Okay, you're not talking to me. I would have argued before we did this study with over 500 people, the N is now 700 men and women of color, it would have been the one about sexual abuse. I would have said that better predicted symptoms of depression and PTSD, but it didn't. Who said one? That's it. And we don't ask about it. Isn't that something? In the last month, have you ever been discriminated against because of your race, nationality, gender, or sexual orientation? And then from there, we go on to what kind of discrimination you have experienced. Now, what do you think is the type of discrimination that is the most predictive of symptoms of depression and PTSD? You won't guess this one. It's social isolation. That's when people ignore you. They don't talk to you when you're speaking at a conference. That was a joke. But you're essentially ignored. That is more damning as a type of discrimination than what you might think. And so in talking about social isolation and social discrimination, it's extremely important to use what I would consider to be the methods that Cheryl Grills uses at Loyola Marymount. And what she does is an emotional emancipation intervention. This is for people who have experienced depression or their groups have experienced depression. And what they do by group and then by interaction is to talk about those experiences. So the first thing I would do in a treatment format is get people to tell me their stories. We do this in research and we do this in my practice. Write it, speak it, bring me records that tell it. I've actually had people bring in different records that tell the story of discrimination and how they felt after having been stigmatized. They can bring pictures. They don't have to use words, in other words. Some people have no words to express what they've experienced in their lives. So we have so much to do because this kind of research is what we need in order to better understand some of the health problems like cardiovascular disease, which is very predictive of histories of racial discrimination. Now, we've been looking at obesity. People will parcel it out and say, you know, we have a problem with obesity. We have a problem with discrimination. And if you don't get to the roots of why people are overeating and eating comfort foods, you're not going to be able to address the problem. They're eating to make themselves feel better. It's not a matter of bad diets. So we've just begun in this area, and I think it's very challenging because in the labs, we're just beginning to recommend its use and to recommend that other people ask these kinds of questions. Not being able to afford to take care of one's family can be a huge source of depression. But so can also sexual abuse, both in childhood and adulthood, and interpersonal violence. So some of the things that you saw may be other items that people don't ask about. We have to get out of the box. We have to diversify our practices. We have to ask questions that are relevant to the people that we're talking to. And if you, at the end of a session, don't ask, have I ever asked you things, or have we ever discussed things that really aren't on your mind, that really aren't important to you, let me know. Because I think the more humble we are as clinicians, as mental health professionals, the more likely we are to listen to the people that we help and change as a result of it. So mine is Dr. Sisuk, number 5. It's the doctor. It's the doctor that needs to change. We need differences in our training programs, and I'm right at UCLA just waiting to be asked to standardize what I just shared with you and train mental health professionals in a very different way. Thank you.
Thank you, Dr. Wyatt, and that's terrific. That's just eye-opening stuff. I'm reminded that social isolation, it brought back a little trauma for myself. When I was a teenager, I went to the Blue Lake Fine Arts Camp on a violin scholarship, and I went there, and the first day I had lunch by myself, and no one sat with me. And to this day, 45 years later, it still sticks with me. So that's exactly what you're talking about. All right, so I get to bring us home talking about a little cannabis. So she's clapping. There are no cannabis in the goodie bags or the giveaway bags. This is an emerging trend. So after finishing residency, I did addiction fellowship, and I started our UCLA Gambling Studies program in 2005, and we built a state-funded treatment program for gambling disorders. But then in 2016, there was starting to be rumors in our department to say, well, we know we have legalized cannabis coming, and what are we going to do as a department to examine that? So we created the UCLA Cannabis Research Institute, or initiative in 2016, as a way of examining the impact of cannabis on body, brain, and mind. I'm an addiction psychiatrist, so I came at that with the perspective of how do we limit the damage of cannabis on addiction. But along the way, and we've all had this, we've had more and more patients and educators and clinicians to say, hey, I think cannabis is amazing. I think this could solve depression. Well, let me give you the facts of where we are with that right now. First, I get some research support from Creative Care up there in the Valley and now in Calabasas, where we're looking at characteristics of early leavers from residential treatment. In other words, trying to figure out why do people leave a 30-day program on day 7. So that would be a good thing to figure out, right? Number 2, I also work very closely with Connections in Recovery. Lauren Casey, Patty Bure, and Lauren Abario, working with Recovery Companions to provide mental health and substance use disorder treatment in the home and improved treatment delivery. And lastly, I work with Kindbridge, which is a telehealth company that provides telehealth for gaming and gambling disorders. But I don't receive any funding from the cannabis industry, and there's a reason for that. Number 1, federal government does not like us to do that, and nor does UCLA. So, what are the accepted therapeutic uses of cannabis and cannabinoids? What's on the shelf right now that I as a physician can prescribe to patients to make their lives better? So, it's a very short menu. First, we have synthetically made cannabinoids, and these are dronabinol, marinol that we use for chemotherapy-induced nausea and vomiting, as well as appetite stimulation for HIV/AIDS. Not something that most of us mental health practitioners are going to use. Got it. Other synthetic cannabinoid is one called nabilone, which is also used for chemotherapy-induced nausea and vomiting. These are hospital-based stuff, really not going to be happening in any sort of residential treatment program or sober living or even outpatient. Really no applications for mental health. Those are synthetically made, person-made, not man-made, person-made compounds that are FDA approved and very, very expensive. The first plant-derived cannabinoid is called Epidiolex, which came out a few years ago with much, much fanfare. And essentially, it's derived from cannabis, and it's a liquid, 100% CBD, 100% cannabidiol. There's no THC in that. It's not psychoactive, and it's FDA approved mainly only for the use of really severe pediatric seizures that are treatment-resistant seizures that have failed all those other anti-epileptics. This is not something we would use in mental health. This is not something that's available, quote, off-label for practitioners to be prescribing for folks. It's very expensive, thousands of dollars for 1 month. Or I could walk down into Westwood and for $40 buy CBD, THC, tinctures, edibles, vapes, wax, shatter, you name it. So the question really is, as we've now gone into a world of cannabis in the last 5 years, can cannabis or cannabinoids be effective for depression? So let's think about that. First, the promise and potential of these compounds. First of all, in our bodies, we create our own cannabis. We have our own systems of endocannabinoids, which is completely different from the opioid systems or the serotonin systems or the dopamine systems. So wait a minute. If we can actually use the power of the plant, the power of cannabis, then we'd have a, quote, naturally derived alternative that's targeting a very new, different system. Dr. Leuchter mentioned that. Wouldn't that be interesting if we targeted the endocannabinoid system instead of dopamine, serotonin, epinephrine, and all the ones that we do with other antidepressants? And hasn't humankind been using cannabis for thousands of years, which means we can tolerate it, which means our bodies like it. And here's the thing. Isn't this something that people would be more willing to take? Would be people more willing to take cannabis bought from a dispensary than, say, Prozac prescribed them by myself? Probably. What about the idea that you're not going to, quote, overdose like you would from benzodiazepines or stimulants or other medications? Affordable. Imagine this idea that you can get cannabis and have no prior authorizations. You don't have to deal with insurance companies. You can roll in to any of these dispensaries and spend something affordable, $10, $15, $20, and get psychoactive doses very, very cheap, and not have to deal and worry about the pharmacy looking at you funny. You could also have potential crossover benefits where the cannabis might also help other things that we know cannabinoids work for: chronic pain, insomnia associated with medical conditions, inflammation, anxiety. But here's the other kicker. We all know someone who knows someone. Maybe they're from Niagara Falls, maybe they're someone's second cousin, who took a couple edibles and somehow were amazingly cured. Johnny or Jill or Jane, did you hear about them? They started using cannabis for depression, and now they are amazing. They're so much better. That rumor mill, right? That almost disinformation that we hear. So we hear that. So all that has created this fervor, this promise and potential of cannabis as a potential treatment for mood disorders. But you think about it, wait a minute, what would make something a medicine? What would make something effective as a medication that would restore normal functioning, right? Drugs are substances that change how our body functions. Medications are drugs that restore normal functioning. The problem is that the cannabis plant, when we open it up and look inside, there are hundreds of chemicals inside that are psychoactive, that are also active on the body. Those are, of course, the cannabinoids, well over 100 of them. THC is the most popular and most widely known cannabinoid. The number 2, of course, is CBD. But there are others, CBG, CBL, and the list goes on and on and on. And all of them are mushed together in that single plant. So when you are taking cannabis, whether you smoke it, you eat it, or you use a tincture or a little oil, what's the active ingredient? When I take Prozac or fluoxetine, yes, it's packaged with a lot of other stuff, but the active ingredient that I know is binding to my serotonin receptors is the molecule of fluoxetine. When I take aspirin, when I take Tylenol, we know what the active ingredients. You don't know that when you have a compound of cannabis. What's the recipe? You hear a lot of myths and stories about, oh, you need 5-to-1 ratio THC to CBD to be effective. And you need to take it with you facing south on a Wednesday, with the wind blowing in this way, with your arm raised, right? That doesn't sound like medication to me. That sounds like a lot of like mythology and superstitions. Do we have any medications? I asked the panel, do we have any FDA-approved medications where you actually are combustible and smoke it? We're laughing because we know the answer to that is no. Because when you smoke something, you introduce any substance in your body in an unreliable fashion, and you create more damage by burning your lungs. Last time I checked, when you can't deliver a medication safely, that's not a medication that can be safely used. What's the proper dose? 5 milligram, 10 milligram, 20, 30, 40? We have no idea. And unfortunately, right now, cannabis is Schedule 1, which means the federal government still views it as no medicinal benefit of any kind, a highest abuse liability. I believe in the next 3 to 5 years, we will see that changed, but that day is not yet here. And last, we have tremendous, highly individualized response to cannabinoids. So in this room, we all took the exact same cannabis gummy, 5 milligrams of cannabis gummy. We would have about 80 different responses. Some would fall asleep within 20 minutes. Some would start dancing on the table. Lauren Casey. Some would get very disinhibited. Some would start feeling relief. Some would start getting paranoid and actually hallucinating. So that speaks to the wide variety of effects of cannabinoids, again, because you have well over 100 cannabinoids, even in one little gummy, but also the individual differences in pharmacokinetics, pharmacodynamics, genetics that we all experience and feel. Very interesting stuff. So the question begs and remains in 2022, April, can cannabis be used for treatment-resistant depression? My answer to that is the promise and potential is possible, but the reality is not there yet. We don't have time travel. We wish we had time travel, but we don't. And so unfortunately, the reality of the current situation, based on current scientific literature and all major medical societies, that there's no room for cannabis to be used for the treatment of mood disorders. These are 2 excellent review articles, and I'll summarize what they say. Currently, the evidence is nascent and too weak to recommend cannabinoid-based interventions for a wide range of psychiatric disorders, including major depression, PTSD, and ADHD. There's scarce evidence to suggest that cannabinoids improve depressive symptoms, disorders, anxiety disorder, ADHD, and the list goes on and on and on. There are really interesting things. If you were to list the side effects of cannabis, immediate, short-term, within the week, and long-term, and you were to map those out side by side to other FDA-approved antidepressants, you would say these side effect lists isn't even close. The cannabis side effects is much, much more greater, much more damaging, and much more long-term. We're talking about a 9% chance of developing addiction from the very first time you ingest cannabis. That's not true with any of our existing medications available for depression. So here's an example where our American Psychiatric Association, their official action, their position state is to oppose cannabis as medicine in its current state today. That's not to say that we oppose cannabis as potential medicine down the road, but we need to do it properly. We need to have a lot more scientific approach and scientific value and scientific process to go with that. So again, the issue that I have, and people are like, well, why don't we use it? The problem with cannabis and medicine, again, the products that are commercially available are too heterogeneous, too unknown, too all over the place in terms of accuracy and consistency. The problem that I have is when people reach for cannabis first to treat their depression and they avoid everything else you heard today that works. Medication, psychotherapy, TMS, ketamine, residential treatment. You can't use cannabis as first-line treatment and say, I'm not going to bother using those other treatments that work. It's still pretty expensive. Although cheap, you can easily walk into any dispensary, right, and spend $300, $400, $500 in cash and walk out with enough cannabis only for about a week. So I think that's an issue that we don't think about enough. And again, we have very little knowledge of what happens when you have prescription medications combined with cannabis in terms of drug-to-drug interactions, all sorts of possibilities there. And again, lastly, if I had 30, let's say, gummies in my home that I'm using, quote, for medicine, and they're just in my home, well, what about my kids? What about the pets? What about the people that come in there? There's oftentimes, unfortunately, unintentional exposure, diversion, and unfortunately, poisonings. So for physicians in the room, there is standards of practice. If you are interested in considering cannabis as medicine, the Medical Board of California has put out a very interesting guidelines on what you're not supposed to do. And remember, for years, we would have this system of medical marijuana in California where you would get a recommendation from a doctor and you would never see the doctor again. That's not medicine. That's like a loophole in my mind. And we still have some medical marijuana physicians out there, and the only reason they're out there now is because you get a little bit of a discount when you buy it inside the dispensaries. But essentially what we have here is what the medical board says. You need to actually have a patient-doctor relationship, examine, document, have a treatment plan, and monitoring. And right now we don't have that for cannabis out there. And part of it as well, we don't have a lot of education for physicians about cannabis. So I'm leaving you with a roadmap of what I think behavioral health's role should be for cannabis and depression. I think our number one goal is to prevent the ongoing spread of misinformation and disinformation. Prior to the pandemic, I never would have thought that this would have been part of my job as a doctor. Now, absolutely it is. So for those of us in behavioral health, when we get a client who comes in and says, please let me use my edibles for my PTSD because this is the only thing that's helped me. We really need to listen to that and hear that, but also make sure and recognize that we don't have misinformation and disinformation spread. If you're working in a residential program, you need to have a clear policy of what you're going to do about cannabis for your clients and your staff. Are we going to allow it? Are we not going to allow it? Are we going to kick out clients who use cannabis legally during the course of their 30-day residential stay? I don't have an answer for that, but I think that needs to be looked at very, very closely. But for clients who do have a positive response, who do come back and say, you know what, I used 5 milligrams of this gummy and now I can sleep a lot better, I think we need to document those experiences for sure. But as an addiction psychiatrist, we absolutely have to screen and detect instances with our clients with active depression that may have underlying cannabis use disorder underneath that's driving that depression. Cannabis use disorder of all the other addictions sometimes is harder to spot. It's not easy to detect sometimes. I think that's important as a reminder that creates depression. And lastly, remaining open-minded about the potential therapeutics of cannabinoids. The one that I think is the closest is CBD by itself for the treatment of psychosis. Would you believe that? That's where the most data exists there for that. CBD by itself for depression, the data is not very good. But we need time, and we need research, and we need a lot of energy and people to work on that. Here's our website for our cannabis research initiative. We have videos, we have conferences, we have all sorts of clinical research trials where we are now recruiting men and women for cannabis. And there's my contact info, my email, our Twitter handle, my Twitter handle, where I try not to spread out disinformation. I see Renee here. That's going to end up our panel, but we will take a few minutes for questions as we head up into the break. I want to thank everyone for their patience and their energy and for listening, and for our panelists for providing really wonderful clinical pearls of wisdom for managing treatment-resistant depression. So the conference is off and running, so we'll take a few questions. Genesis, where are you, Genesis? Let's grab a handheld mic, and we'll take a few questions. And if you go ahead and introduce yourself, who you are, and shout out your question, and we'll do our best to answer it.
Polly? Hello, I'm Polly Young-Eisendrath, and I'm a psychologist, psychoanalyst. I teach at the University of Vermont in the Department of Psychiatry. I appreciate very much, really, the depth, the thoughtfulness, everything about the panel. And Dr. Wyatt and Dr. Zizuk focus specifically on the issues of diagnosis and doctor. And my question is about shame-based disorders. I didn't hear anyone talk about shame, and it seems to me that there's a lot of confusion in regard to depression and shame. Shame being a global evaluation of the self as negative or a deficit, and that can often create what could be called some kind of resistance to treatment, also to medication, and even to getting to know mental health practitioners. And so I'd love to hear what you have to say about shame-based disorders, how they interact with obsessive-compulsive personality disorder, for example, and the confusions that may come up in regard to depression for clinicians. But thank you so much. I'm just adding one more thing.
That's right. Did anyone want to take that? I'll just say one thing about that. One of the things I've learned over the last few years, the antidote to shame, of course, is empathy. And talking about it. And I think that was something that I did not learn in residency. And it took me a long time to actually learn that in real life. So I'll turn to our panel. Anyone want to comment on that, shame-based? Dr. Wyatt and Dr. Zizuk will have comments.
I can address some of it. Thank you, by the way, for your kind words. I did talk about obesity. Obesity is an epidemic, in the United States. And many people attribute it to poor diet, the wrong models, body models, Instagram. I mean, you name it, people have talked about where all of this comes from. What I'm trying to propose is obesity has a root in trauma, and that in interviewing people, we really do need to ask them about experience of discrimination and trauma. Many times that this is a way of self-medicating by overeating, and I think that's shame-based because people make fun of individuals who are obese. So hopefully addressing your concerns in some way. It's not connected to the outcomes that you wanted to discuss. I don't have any information on that, but I do know that shame is quite significant in many communities of color if people don't meet the metrics of how we're supposed to look or the stereotypes that people expect us to live up to.
Thank you. Dr. Zizuk.
It's a really interesting question, and I haven't thought about shame-based disorders, and off the top of my head, it's hard to comment too much on that. But in the kind of people I work with and treat, shame is a core component, and I think particularly in two instances. One is physicians and other healthcare workers who experience what we sometimes call a second victim syndrome, where a patient has a difficult, challenging, bad outcome, sometimes based on a decision we've made, sometimes based on a medical error, not always. And that the almost ubiquitous response to that is shame. Someone else could have done better, I'm an imposter, what did I do wrong, I don't want anyone to know. Where we see it, every specialty has their own second victim syndrome scenarios. In psychiatry, it's when a patient dies by suicide. Many of us have experienced patient death by suicide, and who here hasn't, in the context of that, felt shame and not wanted to talk about it and felt that they're to blame and they don't want other people to know about it. The first patient I had who died by suicide when I was a resident, I remember my supervisor didn't talk about it with me. I didn't talk about it with my supervisor, with the person who referred the patient to me. I didn't even talk about it with my wife because one of my reactions was deep shame. And I think we don't pay enough attention to that. And the best antidote I know to shame is conversation, discussion, talking, to recognize that we're not alone, that we're all human, and none of us are perfect. And so I do, and shame is a core part of depression. I don't know if depression is shame-based. I do know when you're depressed, you're more vulnerable to feeling shame, and that the more shame you feel, the more difficult that depression is going to be to manage unless you very directly deal with it and relate to it, talk about it, and incorporate that into your overall treatment strategy.
We are running up into the break, so we're going to go ahead and take our break. Panelists will be hanging out for a shade more time. If you want to come on up and ask us a few more questions and comments, and give yourselves a round of applause. Thank you. See you next year.
Hello. So we're going to push back just a couple of minutes. So I'll be back here by 10:55. But please go support our sponsors. We're giving away some raffles this first time around. I pushed lunch back a few minutes so we don't miss anything.